Gender transformations. Before we can talk about this in detail, we need to cover some terminology. Genotype. Your genotype is what you are born with. For example, females are born with the genes XX, and males are born with an XY genotype. Sex. This refers to the genitalia you are born with. Phenotype. The physical characteristics that are male or female in appearance. For example, males can grow a beard, females develop breasts, etc. Sexual orientation is preference for sexual partners, hetero or homosexual, bisexual, asexual, etc. One way you can think of this is, what parts do you have sex with? A heterosexual male will have sex with a vagina. A homosexual female will have sex with a vagina. Gender. This is the identification that makes the most sense to you. For example, you live socially as a female, as a male, or as non-binary or queer. There are legal issues to think of. Different states have different rules about how one can go about changing the name, the sex, etc. on official paperwork. Timing. Gender transformation is a long-term process. We start cross-hormone treatments after a patient has declared themselves to be the opposite gender, and ideally, when they have an accepting social network. The remodeling process takes months to years. Fat redistribution, changes to hip ratios, hair growth or reduction, breast development, etc. Be patient because we go slowly in a stepwise pattern. 3 to 6 months after starting hormone therapy, we are starting to see significant changes. We consider proceeding to surgery after at least 1 year of hormone transformation with good medical compliance. What about preventive health? Well, the rule is if you have the part, we gotta screen it. And that means if you are born as a male sex and have completed hormone transition but have not had any top or bottom surgery, we have to check the prostate for cancer just like we would in any other genetic male. The same goes for any retained breast, ovarian, testicular, uterine tissues, as well as for males who transition to female and develop new breast tissue. All of the usual screening guidelines apply as they would to any non-trans individual. For males at birth transitioning to female, every patient is different in the extent that they want to express gender. Some just want spironolactone, some are happy with medical but not surgical treatment, and others want to have everything remade. The full spectrum of interventions includes spironolactone to block androgen receptors, taken in tablet form 100 to 200 milligrams per day, estradiol to add female hormones to the body, maintaining a goal level of less than 200. This can be done either in tablets 2 to 6 milligrams per day, a patch of 0.1 to 0.4 milligrams twice a week, or injections 2 to 10 milligrams per week. Androgen deprivation, or medical castration, removes male hormones from the body without surgery. The goal testosterone level is less than 55. Leuprolide is an injection given every month, or goserelin, an injection given every 12 weeks. There is a procedure called tracheal shave that will remove or reduce the Adam's apple. Permanent hair reduction by laser or electrolysis. Top surgery, which is breast construction or augmentation. And bottom surgery, orchiectomy and sex reassignment surgery. An orchiectomy is removal of the testes. The feminizing effects of cross-hormone therapy will start between 3 to 6 months and optimize anywhere from 3 to 6 months to 3 years later. If possible, it's important to delay puberty with medication before permanent changes to the skeletal structure, skin and hair follicles, and muscle distribution take place. The characteristic male's broad shoulders, square jaws, and so forth cannot be undone. What about the voice? There will be some change to the voice as testosterone is blocked and estradiol is added. However, speech therapy is the most effective means to achieve a feminine voice. For females at birth who are transitioning to males, again, every patient is different in the extent that they want to express their gender. Some are happy with medical but not surgical treatment, and others want to have everything remade. The full spectrum of interventions includes testosterone, which adds male hormones to the body, maintaining a goal level of 350 to 700 when measured halfway between injections. This is given either by testosterone cypionate or enanthate. This is a weekly subcutaneous or intramuscular injection, or androgel, a topical testosterone that's applied daily, a testosterone patch, which delivers 2.5 to 7.5 milligrams per day, and oral testosterone, which is newly available in the United States. Top surgery would involve mastectomy or reduction in the breast, and bottom surgery would involve oophorectomy, removal of the ovaries, hysterectomy, and sex reassignment. Contraception. If you prefer to have sex with penises and choose to not have a hysterectomy, we recommend an IUD or a tubal ligation. Timelines. Remodeling effects can come on within a few months and optimize anywhere from 1 to 5 years later. When you have questions about this topic and want to have reliable information, we recommend checking out UCSF's Center for Transgender Care, the American Psychological Association about Transgender at apa.org, and the National Center for Transgender Equality at transequality.org.